At the outset, my sincere thanks, Ramesh sir, and actually I owe a lot for my professional experience to this department. When I was doing my MCH, Mathikosh sir, Jubilee sir and Kurula sir, Ramesh joined on me in the later part. That is when I was final year. My contemporary and colleagues, PG, senior PGs, Joshi, Manoj, Madhav, and the juniors Baiju, by all were good to me, and I had learned something from each and every one of them. I had taken something for my professional or my personal life from each and every one of them, and especially for my professional experience, I had taken a lot from, actually I had to say that, from Kurula sir. Because he has given me the chance to explore the abdomen, the anatomical range. He has shown me the anatomical, all the crevices of the anatomy in the abdomen, and the techniques, the tissue respect he has shown to the, although it's very harsh outside, in the operation theatre you should see the respect he's giving to the tissues. That is what I had taken much from this department. So I owe a lot, and thank you sir for the invitation, and I will go to the topic. This will be just some basics, so most of the liver surgeons will be bored. Minimizing the blood loss in liver surgery. So excessive blood loss is still a major concern for all the liver surgeons. It doesn't happen not only in a cirrhotic patient, it could happen in a normal liver also, and definitely it will increase the morbidity and mortality. It is multifactorial, and technical factors also will be responsible. Abnormalities of the hemostatic system also contribute for the bleeding during liver surgery. So it could be improved with your surgical and the anesthesia techniques. We have got better understanding of what is happening with regard to the hemostatic mechanisms in liver disease. Several strategies, perioperative itself, you could look at the evaluation, the full liver function evaluation, what are you going to expect. You could refine your surgical techniques required, expecting a blood loss in the tissues. So you have to act according to the stage of operation or in the pre-operative stage itself. So if you looking for the blood loss, the stages in a liver surgery, the initial part, the hilar dissection, or when you're getting the vascular control, it will be very minimal only unless the patient had a previous abdominal surgery or a previous liver surgery. So it is during the transection phase of the parenchyma that the majority of the blood loss will be occurring. And the next again, the third part, when the checking the resection surface for the hemostasis, biliostasis, and you ensure adequately. So your dissection devices, does it matter? We'll have a look. The dissection technique, does it matter? We'll have a look, and about the tropical agents also. So surgically, the vascular control, if you want to achieve a full control over the liver, you want absolute blood loss, it is a total hepatic vascular exclusion. It has got its own problems. Otherwise, most of us will be favoring a Pringle maneuver or a continuous or an intermittent type of Pringle. And regarding the dissection techniques or the parenchymal transection techniques also, we have a lot of instruments available now. You could still rely on the finger fracture technique, the other types of the machineries. So we look into each and every aspect in minute details. Continuous clamping, with the problem with the continuous clamping, this will give the best of the, that is the Pringle maneuver, that is the best of the blood control, bleeding control, but it produces planktonic congestion and will be prolonging the parenchymal ischemia also. There will be bowel edema leading on to the, if you prolong it too much, it will lead on to difficulty in the closure, and there may be prolonged ileus. Hyperamylesema, even pancreatitis has been described. Normal liver, it could tolerate even up to 60 minutes of warm ischemia, that is the usual recommended times. So much favored nowadays is the intermittent type of Pringle. You do a 5 minutes duration of unclamping, and at that period of unclamping, the surgeon should not try to transect during that period. He should have just gentle compression of the transected surface, and he should examine for the oncological adequacy, is he going in the right plane, and he should also respect the vascularization of the remaining liver. Precondition, an important aspect, very much discussed in detail, that is giving an initial period of ischemia and then allowing a reperfusion. And after that, they say that it will even tolerate a continuous clamping for up to 60 minutes. But this, theoretically, it's a very good strategy, but its clinical importance is very controversial. Not much has been applied with regard to the preconditioning in later on. So hepatic total vascular exclusion, where you have the control over the suprahepatic IVC, infrahepatic IVC, and the Pringle, will give you you will be able to do the tumor resections in absolutely bloodless way. It has got its own consequences of clamping, as I had already mentioned. The anesthetist also should be very much favorable or very much familiar with this type of the clamps that you're using. But it is still useful in certain conditions when you're dealing with a large tumor adjacent to the IVC or to the major hepatic veins, because that are the most difficult tumors to resect. Even they may not be very much large size, but the location will prevent it will produce a venous congestion, and even if you apply the Pringle, there will be a lot of bleeding in these cases. So in such occasions, and rarely, this type of vascular control may be required, and sometimes you may be forced to ensure a hypothermia also, because liver always tolerate the hypothermic ischemia rather than a normothermic ischemia. The anesthesia aspect, a bit on this. What we expect from the anesthetist is a volume contracted state. They have done the phlebotomies, vasodilators have been used, some have used diuresis, and use of blood products also. They have to be careful. Don't fill up the patient with the blood products. Especially don't go and correct a cirrhotic patient with the INR a bit higher on the ISID. If you push in these FFPs or other agents, they just fill up the patients and the bleeding will be more. Use of pharmacological agents have also come up recently, antifibrinolytics, recombinant factor 7A, and the Octoplus that is familiar to us. This has been very much well tried and established that in transplant scenarios, it has definitely decreased the blood loss. In a normal liver resection, we still need some good trials to say that they are of benefit. So low CVP could also be a problem. Air embolisms, systemic tissue hypoperfusion leading on to the high lactate and the problems associated with it. It also could lead on to the renal failure. So message is, for the anesthesia part of the point that it should be strongly influenced by how much control you require is influenced by the filling status and the CVP of the patient. Don't go and correct all the laboratory coagulation tests with large volume blood products, because it is not effective and it's not safe also. We need some good prospective studies to say that phlebotomy is required, diuresis is required to establish a low volume contracted stage. No more volume is also okay. That is what nowadays the liver surgeons and the anesthetists are coming up to. Strategies to decrease the blood loss: you could use the topical agents, antifibrinolytic drugs, procoagulant drugs. Topical agents, we are all familiar with the fibrin seals, or there may be a matrix like the surgical Surgicel that we are using. These all initiate the coagulation process. And there are combined products also. There is a matrix of combination, and there is some factors that will mimic the coagulations. Antifibrinolytics, we have used mainly the two groups, the inhibitors of the plasminogen and inhibitors of the plasmins. The first one is that is commonly used in our part of the world, that is a tranexamic acids. Extensively used again in the liver transplantation scenario, where there is a 40% reduction, but it has not found much help in the partial hepatectomies. Procoagulant drugs, the recombinant factor 7A, I don't know how much of use or practice you people have, but the Octoplex, we ourselves have got some practice, especially in the transplant scenario, and our anesthetist is very fond of using these drugs. So if you look at overall, if you want a safe liver surgery to be done, there should be good vascular control and inflow and downflow, and transection should be in the anatomical planes, then you get less blood loss. And always try to use the anterior approach and the hanging maneuver. Dr. Shabir Ali has already highlighted here. So anterior approach should be used for large tumors. I'll just go through a video where I could actually highlight upon some principles of the vascular control. This is a large, actually it's a hemangioma, but it was causing a lot of symptoms to the patient. You could see that it's very large, and you could see we have used the anterior approach. It is almost skirting on the middle hepatic vein. So such a large tumors, always there is a chance that there could be a bleed during many part of the surgery, mobilization part, but this was done laparoscopically. Laparoscopically, it doesn't, just because the tumor is very large doesn't mean that laparoscopy never should be done for the patients, because there are several areas where laparoscopy will be helpful in these patients. You see that this is just a suprahepatic, the exposure that is given by the laparoscopy in these areas, the porta, dissection and all, you could see that. With a large tumor hanging down in open surgery, you will have to lift up such a kind of tumor with to see the porta, to approach the porta. Your camera exactly goes to the porta. That is the advantage with the laparoscopy. So you do the initial portal dissection, you get the vascular control. This is just a 2-minute video. So here it is a portal vein getting dissected. Sorry, that is the artery that was divided. You could see the anterior and the posterior. There are 2 portal veins here. So it is the anterior and the posterior portal veins that are getting dissected and they're getting clipped. I'll finish with this video. Anterior portal vein that is also getting clipped. So this, you ensure a good vascular control initially itself, any type of, whether it is open or if it's a laparoscopy, and then you mark the transection line here, and you could see the line of demarcation that has happened. And during the transection itself, you could notice that there is a Foley that has been kept. If required, a Pringle could be applied. And this dissection was mostly done without any Pringle application. You expose the veins, you go along the anatomical planes whenever possible. If you're doing an anatomical resection, you could minimize the blood loss. That's a segment 5 vein that is getting isolated and it will be clipped there. The rest of the transection goes along because on the upper part it will be skirting the tumor, because you had seen that the tumor is almost very much close to you. Whichever type of the energy device or the QSI you are using, just be familiar with the way to use it. That is the most important. This is the pedicle part that is coming up. You could see the duct that is going to get isolated and the ECG has been given, so the right duct is divided. So the rest of the dissection is further continued. You could see the MHV skirting on the, and whenever such a bleeding occurs, you just control with some pressure. That will help you in getting control. Mobilize still more in the parenchyma and get a good control. This is the RHV. So by the anterior approach, you could see that you are directly hitting on the cava. Once you complete the transection, you're hitting, and then rest of the mobilization is done on the cava and just pushing the tumor away. You have not touched such a huge tumor at all. You just need to push the tumor or the liver away from the IVC and clear the IVC completely. So that is all the advantage that you get with the anterior resection. Here there was no attempt to do the hanging, but hanging was not required at all, because you could directly approach from the cava and upwards. You could, once the porta is being divided, you are on the cava. So the tumor extraction may require a bit of struggle, but it will be only a small phalanx steel incision. And with that end up. I'll summarize that perioperative blood loss. Perioperative blood loss and transfusions have a negative impact on the post-operative outcome of the liver surgeries. Surgical technique and experience are key factors. Inflow occlusions and the use of low CVP definitely helps. There is no superiority of one dissection device over the other. And live donor liver resection is the best illustration that major liver resections could be performed without clamping and without transfusion. Thank you all.